Good afternoon. On behalf of the Circulation Cardiovascular Imaging editorial team, including Professor Gropler and Professor Negishi, would like to welcome you to today's webinar on myocardial fibrosis in elite athletes, biomarker or risk. My name is Chadi Ayoub. I'm an imaging cardiologist and professor of medicine at Mayo Clinic in Phoenix, and also serve as the digital media strategies section editor for Circulation Cardiovascular Imaging, along with my colleague, Professor Negishi, who is from Liverpool Hospital in Australia and leads the Negishi Research Lab there. We are very excited to introduce today's topic centering on athletes' heart and MRI imaging. The effects of high-level athletic exercise on the heart has always drawn much interest and even intrigue from cardiologists, physicians across medicine, and the general community. And therefore, it is a treat that we are pleased to introduce the authors of two blockbuster papers that have just come out in Circulation Cardiovascular Imaging on this topic involving cardiac MRI imaging, and they will share their insights with us today. In terms of the format for today's webinar, we will present the authors of the first paper, and then followed by that, we will invite our expert editorialists to make their comments about insights, and then we'll present the authors of the second paper on this topic, followed by the editorialists to make their comment as well. We'll leave about 10 to 15 minutes at the end of the session for active question and answers from you, the audience, and we would encourage you to participate. It's a very exciting topic, and please use the Q&A feature through this Zoom interface to pose your questions so that we can have our experts weigh in. And with that, I'll pass it on to Professor Negishi to introduce our first paper and speakers.
Thanks very much, Chadi. Hello, everyone. It is my great pleasure to introduce the first paper, and we have two presenters from the journal, first author and also the last author. The first author is Dr. Wasim Javed. He's a UK-based cardiology registrar in his final year of the training with the subspecialty interest of cardiac MRI, cardiac CT, and inherited cardiac conditions. He completed his PhD at the University of Leeds in 2024, where he investigated the association on cardiac fibrosis with the arrhythmia in veteran endurance athletes, which is the topic of today's paper. And the main project from this study, called the VENTOUX, has received several international awards, including the European Society of Cardiology and British Cardiovascular Society. Congratulations. And his future aspirations include further assessing the mechanisms and sequelae of pathological remodeling in athletes. I also would like to introduce the senior author of this paper, Dr. Peter Swoboda. He's an academic cardiologist from Leeds, UK, and he has expertise in cardiac MR, sports cardiology, and heart failure. He's also an experienced marathon runner. That's great. With that, the title of the talk is Ventricular Arrhythmia and Cardiac Fibrosis in Endurance Experienced Athlete, VENTOUX Study. Over to you, Dr. Javed.
Many thank you for that warm introduction. So today I'm delighted to present our study called VENTOUX, which was conducted at the University of Leeds. Sudden cardiac death is the leading medical cause of mortality amongst athletes, which is thought to predominantly affect older and middle-aged male athletes. Traditionally, undiagnosed cardiomyopathy was believed to be the main underlying reason. However, more recent studies shown here on the left-hand side have shown that actually a significant proportion of athletes who die from sudden cardiac death have a structurally normal heart on post-mortem, raising the suggestion that primary arrhythmia may be a key cause of sudden cardiac death in athletes. And despite progress made in recent years to improve the survival rates following sports-related cardiac arrests, the total number of arrests occurring appears relatively constant, as seen in the right diagram here, which really illustrates the need to improve our understanding of the mechanisms of sudden cardiac arrest and death in athletes in order to help prevent this from occurring. In a well-known study by the St. George's Group in 2016, the two main post-mortem findings in older athletes who suffered sudden cardiac death were either a structurally normal heart or idiopathic LVH and fibrosis on post-mortem, and these accounted for over 50% of the deaths in this over 35 group. Panel C here illustrates a case of idiopathic LVH and fibrosis, which interestingly varies histologically from hypertrophic cardiomyopathy, as there is no histological evidence of myocyte disarray. And then several key studies have also demonstrated the prevalence of myocardial fibrosis on cardiac MRI in healthy athletes, with reported prevalences as high as 50%. And this appears to affect the basal infralateral segment in a non-ischemic distribution, as seen in this diagram here. Now, overall, these studies suggest that it is actually older male endurance athletes who chronically undertake high-intensity aerobic exercise who are most likely to be affected. However, there is a wide variation between the studies, which themselves are limited by retrospective design and inconsistent methods of reporting fibrosis. Some important work has been carried out by researchers in Italy who have shown that in young competitive athletes who present with ventricular arrhythmia during exercise, and the ones who have a basal infralateral type of fibrosis on cardiac MRI are more likely to develop recurrent ventricular arrhythmia during exercise testing than those without this pattern of fibrosis. However, we don't know what the significance is of fibrosis in healthy older athletes without a prior history of arrhythmia, as there are no robust prospective data to answer this important question. And with this in mind, we conducted VENTOUX, which was a prospective study investigating 106 healthy male veteran endurance athletes for fibrosis and its association with ventricular arrhythmia. Inclusion criteria consisted of being a competitive male cyclist or triathlete aged over 50 years old who trained for more than 10 hours per week for more than 15 years, whilst exclusion criteria consisted of any known cardiovascular disease, including hypertension, prior arrhythmia, or symptoms suggestive of cardiac disease. Athletes were recruited via invitation to local and national sports clubs, and the advert was also placed in a national cycling magazine. And the study gained media coverage when a UK-based news channel aired it, and we received interest via this method as well, and that footage can be seen in the top right corner here. Each athlete underwent comprehensive stress perfusion CMR with advanced late gadolinium enhancement imaging techniques. A control group of age-matched male non-athletic controls were also recruited to undergo an identical CMR protocol to identify whether the observed prevalence of myocardial fibrosis was specific to athletes. Inclusion criteria and exclusion criteria for this group were identical to the athletes. However, they were required to undertake less than 3 hours of formal exercise per week. The athletes then had an ILR implanted, which was a Biomonitor 3M made by Biotronic, which can be seen here with its flexible long antennae designed for superior sensing. And then each athlete underwent an exercise test on a Wattbike Pro, which was designed to quantify their fitness levels and record the maximum heart rate during exercise to help set the ventricular arrhythmia threshold on the ILR. We then followed up each athlete daily for 2 years for the endpoints, the primary endpoint of sustained ventricular tachycardia, which was 30 seconds or more, broad complex tachycardia, and the secondary endpoint of non-sustained ventricular tachycardia, which was 3 or more beats of broad complex tachycardia. And all endpoints were agreed upon by an arrhythmia panel, which included a consultant electrophysiologist, and who was actually blinded to the fibrosis status of the athletes. And then athletes also had an online symptom diary where they could upload any symptoms that they had. In terms of the CMR protocol, this was performed using a 3T Siemens Prisma scanner. We performed cine imaging in short axis stack and multiple long axis planes for volumetric analysis, quantitative myocardial perfusion using adenosine in rest and stress imaging, to identify myocardial ischemia, and pre and post contrast T1 mapping to allow estimation of ECV. We also performed T2 mapping to ensure that there was to identify any inflammation or edema, and then performed motion corrected bright and dark blood LG imaging in short axis stacks and multiple long axis planes to identify and quantify fibrosis. And the fibrosis was confirmed by two independent CMR experts, and it was only deemed present when it was present on both bright and dark blood LG imaging along with ECV maps, as can be seen in the bottom right corner of this diagram. Fibrosis was then quantified using a 5 standard deviation method. Whilst RV insertion point fibrosis was recorded, we did not classify that as true fibrosis. So on to the results now. So we found that 47% of athletes had fibrosis on CMR, all of which was in a non-ischemic distribution and predominantly affected the basal infralateral segment in 88% of cases as seen here. Furthermore, athletes had a significantly greater prevalence of myocardial fibrosis than non-athletic controls, 47% versus 11%. In terms of the athletes with and without fibrosis, so athletes with fibrosis were significantly older than those without. They also had a greater prevalence of exercise-induced PVCs than those without fibrosis, but there were no other significant differences in any demographic, training, or CMR characteristic between the groups, with CMR findings highly characteristic of athletic remodeling between both groups. Also, it's worth noting that the RV insertion point LGE was highly prevalent amongst the entire cohort, with the fibrosis athletes having around a 68% prevalence compared to 82% in those with true fibrosis. And this box plot just illustrates the correlation of older age with the presence of fibrosis, but no other variable was associated with the presence of fibrosis. In terms of the incidence of ventricular arrhythmia, so 23 athletes experienced at least one ventricular arrhythmic event over a median follow-up of 720 days. Of these, 3 athletes experienced VT and 20 experienced non-sustained VT, so around 3% and 19% of each, and around 22% of the overall cohort. And those who suffered ventricular arrhythmia, well, in terms of the ones who developed sustained VT, one of them required an ICD, but the non-sustained ventricular tachycardias were all asymptomatic. When we compared the athletes who suffered ventricular arrhythmia compared to those who did not, we found that the athletes with ventricular arrhythmia had a significantly greater prevalence of non-ischemic fibrosis, which was 39% versus 78%. They also had a greater left ventricular end-diastolic volume in the arrhythmia group and a greater prevalence of exercise-induced PVCs. All athletes who experienced sustained VT had myocardial fibrosis on CMR, and 12 athletes developed recurrent ventricular arrhythmias. Of those 12, 11 had myocardial fibrosis, which is around 92%. Furthermore, as can be seen at the bottom of this table, RV's insertion point LGE was not significantly different between the athletes with and without ventricular arrhythmia. By Cox regression analysis, the presence of fibrosis was significantly associated with an increased risk of ventricular arrhythmia with a hazard ratio of 4.7, and this remained significant even after correcting for age. We can see here as well that LV end-diastolic volume was also significantly associated with ventricular arrhythmia. On a multivariate model that we performed, we found that fibrosis remained statistically significant when combined with this variable. And this Kaplan-Meier curve illustrates the significantly increased risk of ventricular arrhythmia over time in those with fibrosis compared to those without fibrosis. And this is 2 examples of participants from our study who both developed ventricular arrhythmia. Both were over the age of 60. On the top here, we have a mid-wall distribution of myocardial fibrosis, and you can see that the LV and the RV dimensions are markedly dilated with borderline low function. And on the bottom, we have a 64-year-old who also developed non-sustained VT, but with normal biventricular size and function. And the pattern of fibrosis in this participant is more subepicardial. To summarize, this VENTOUX study was conducted in older male cyclists and triathletes who were undertaking a high amount of high-intensity exercise that had done so for years. It demonstrated approximately half had fibrosis on CMR, which is all non-ischemic and mainly basal infralateral in distribution, and it was significantly greater than age-matched controls. Those with fibrosis were almost 5 times more likely to develop ventricular arrhythmia than those without fibrosis. And furthermore, RV insertion point LGE was not associated with fibrosis. However, it is worth pointing out that the study was limited by the fact that it was performed in a select cohort of older male white athletes, thus limiting clinical translation to other groups. They were also performing a very high amount of exercise and had done so for many years. There's also the possibility of a referral bias, as we invited athletes, and whilst none of them disclosed any symptoms or concerns, it is possible that a self-referral system such as this may have attracted those who were most concerned, and therefore leading to a referral bias. Therefore, our study requires larger follow-up studies involving more diverse ethnic backgrounds, sporting disciplines, and the involvement of females to further investigate this issue. And I would just like to say thank you to the team that made this possible at the Advanced Imaging Centre in Leeds, particularly the CMR radiographers and my supervisor, Dr. Peter Swoboda, who can be seen in the middle here, along with Professor Sven Plein, and on the right is a picture of me with Jonas Vingegaard just before he ascended Mount Ventoux on the Tour de France, although he didn't do very well last time. But thank you for listening.
Thanks very much, Dr. Javed. That was very detailed overview of the VENTOUX studies. It was great. So we now understand the paper more. So before we move on to the next chapter, I'd like to encourage the audience to use the Q&A function for you to put your questions. We will have time at the end to ask these questions. So when this paper was published in Circulation Cardiovascular Imaging, this was accompanied with the editorial led by Dr. Katie McMenamin and Dr. Professor Frederick Ruberg. Dr. McMenamin is the Rising Internal Medicine Chief Resident and R38 Research Fellow at Boston Medical Center. Her clinical and research interests are in cardiovascular disease, particularly the recognition and the management of cardiac amyloid. She also has a personal interest in sports cardiology as an elite marathon runner. The senior author of this editorial was our Rick. Dr. Ruberg is a Thomas J. Ryan Professor and Chief Division of Cardiovascular Medicine at Boston University, Chobanian Adventist School of Medicine and Boston Medical Center in Boston, Massachusetts. He's previously Senior Associate Editor of the Circulation Cardiovascular Imaging and past Director of the Cardiac MR Program at Boston Medical Center. The title of the editorial was The High Intensity Exercise, Fibrosis, and Ventricular Arrhythmias. How much is too much? Over to you, Katie.
Thank you for that introduction. First, I just want to say thank you to the authors for doing this really important work, and of course to Circulation Cardiovascular Imaging for giving us the opportunity to comment on it. So we all know that exercise is great for you. It is essential to cardiovascular health. It is in all of the recommended guidelines for optimal health. But we also know that intense exercise, especially over time, does result in structural changes in the heart. Most of these changes we think are benign and adaptive, but we know there are cases where they can become pathologic. And an example of this is the development of myocardial fibrosis. But before this study, we really didn't know what the implications of myocardial fibrosis were in otherwise healthy and asymptomatic athletes. So it was a really important step forward. As mentioned, the prevalence of myocardial fibrosis that they found in this population is quite high, with almost half of the athletes having it, likely because of their stringent criteria, with athletes being older and just the degree of exercise that they participated in, as well as their male sex. And then most importantly, they found this very strong association with ventricular arrhythmias. And while the overall prevalence of sustained VT was still quite low, even 3 individuals having sustained VT who are otherwise asymptomatic and healthy is really alarming. And the association of that VT with myocardial fibrosis in the study is really the major finding here. It's important to point out that we can't say definitively that the arrhythmias came from the myocardial fibrosis. However, the strong association they found, the fact that almost everyone, close to 100% of people who had ventricular arrhythmias had myocardial fibrosis, and our background understanding of fibrosis as arrhythmogenic and cardiovascular disease certainly make causality plausible. So that leaves us with the question of, where do we go from here? Should we be telling our patients and friends who participate in endurance sports to do less exercise, to rethink that Ironman that they've signed up for? I think the short answer is we still don't know enough. The mechanisms here are still really unclear. We know that exercise acutely places stress on the heart, but how that over time results in pathologic changes in some individuals and how that interacts with other factors is still largely unknown. In this study, we can't rule out underlying genetic cardiomyopathies as a contributing factor. We can't completely rule out microvascular dysfunction. We don't know which, if any, of these athletes may have had subclinical episodes of myocarditis in the past. And there seems to be an interaction with age and sex that we don't fully understand. So I personally don't think that we can make any blanket limitations or recommendations on how much exercise people should be doing, especially knowing that cardiorespiratory fitness is so strongly associated with longevity in general. But it certainly gives us pause when we're thinking about our patients and friends who do endurance sports, especially those who are older and male. And ideally, we would develop some kind of screening strategy. Unfortunately, I think MRI isn't really a viable screening strategy, at least in its current form. But these results suggest that it could be used to risk stratify people who might be at risk for another reason, whether that is frequent PVCs, any kind of symptoms, any kind of episodes of NSVT. Ultimately, I think more work is needed in more diverse populations across the life course, some of which I think we're about to hear about shortly, to better understand how this occurs over time and develop more effective strategies for risk stratification and prevention to ultimately help people participate in endurance sports safely and hopefully prevent sudden cardiac death in athletes.
Okay, thanks very much, Katie. It was a beautiful summary of this work. And with that, I will pass it to you, Chadi, about the introduction of the next paper.
Absolutely. So it's my pleasure to introduce Dr. Sjoerd Verwijs, who is a resident at the cardiology department at the Amsterdam University Medical Center in the Netherlands. His focus is on sports cardiology, mostly applying non-invasive imaging. And together with Dr. Harold Jorstad, he's established the elite cohort of more than 800 athletes in the Netherlands. And this has led to their excellent study on ventricular hinge point LGE and that it is highly prevalent and sex-dependent in elite athletes. So I'll hand it over to you, Dr. Verwijs, to present your study findings. Thank you.
Thank you very much, and good afternoon, everyone. Thank you for the introduction again, and thank you for the possibility to present our work. Today I'll discuss our latest study titled Cardiac Ventricular Hinge Point LGE. It's highly prevalent and sex-dependent in elite athletes, as you mentioned. The learning points for the presentation are firstly the high prevalence in multiple disciplines of elite athletes. And secondly, the high prevalence among male compared to female athletes. Thirdly, that is detectable at a young age, which could raise the hypothesis that it might be a feature of adaptation to intense level training. And based on our findings, we recommend that the presence of hinge point LGE in isolation, especially when observed in structurally normal hearts with preserved function, should not necessarily be interpreted as pathologic or preclude sports participation. Okay, on to the study. As physicians involved in cardiac imaging, we frequently find various patterns of LGE in various cardiomyopathies, such as in dilated cardiomyopathy or hypertrophic cardiomyopathy. In these cases, you can also see hinge point late gadolinium enhancements. This raises an important question, because how do we interpret hinge point LGE in athletes, particularly high performance athletes during pre-participation screening? So hinge point LGE presents a unique challenge, and current studies, as mentioned on the slide, have presented prevalences in older mixed endurance athletes, which is 38%, or 70% in older ultramarathon runners, or 27% in recreational runners. But we aimed to investigate the prevalence of hinge point LGE in the extreme phenotypes of young, healthy, elite athletes, and to stratify it for sex and determine the associations with cardiac remodeling indices. The methods for this paper, the current study, is that it's a cross-sectional study that uses data from the elite cohort, and the data was collected from September 2019 to February 2024. The current study focuses on MRI, CMR data, and excludes athletes with suspected pathology or incomplete CMR data. To highlight one of the strengths of our study, I'd like to briefly touch upon our elite cohort, which is also presented in our 2023 method paper. ELITE is short for the Evaluation of Lifetime Participation in Intensive Top-Level Sports and Exercise, and aims to depict the cardiac baseline of all athletes, all elite-level athletes participating in the Netherlands. So every athlete that is performing at a national, international, or Olympic or Paralympic level is asked to join this cohort. It includes conventional study examination, but it also includes echo and MRI, and it's a prospective cohort. The current study uses demographic data, blood measurements, ECG, and CMR. And our CMR protocol includes volumetrics using short-axis CNA imaging, using a standard method of the summation of discs and at the end diastole or end systole. T1 mapping was calculated in 3 different short-axis slices and calculated before and after gadolinium contrast using a MOLLI protocol with inline motion correction, and we used a 15% margin from the epi and endocardial contours to calculate a global T1 value. We excluded slices with poor data quality, and ECV was calculated using Circle CVI post-processing software. Late gadolinium enhancement was assessed using two data sets using two different voxel sizes, in which the latter is more a high definition data set. It was visually identified, and when we were in doubt, we used a +6 standard deviation signal intensity as a threshold for true enhancement. The primary outcome for the study is the prevalence of hinge point LGE, and secondary outcomes are its prevalence stratified by sex and CMR measurements. Our study included 309 elite athletes, of whom 125, which is 40%, female athletes, with a median age of 25 years and a mean body surface area of 1.9. The top three athletic disciplines included road cycling, 18%, soccer, and there's one viewer in front of my presentation, sorry about that, and hockey players, field hockey players, 12%. Overall, the majority of our cohorts participated in high dynamic sports, combined with varying levels of static demand, and it's 86% of our cohort. The median professional athlete career was 12 years, and the median training or competition time was 19 hours per week. Onto the main results, we found a 40% prevalence of hinge point LGE in this cohort. And if we stratify it for male and female athletes, we found a marked difference, 47% in male athletes and 30% in female athletes. If we look at the clinical characteristics of these of the athletes, and we compare the athletes with hinge point LGE to the athletes without hinge point LGE, we can see we found a lower age of the athletes with enhancement, 24 years versus 25.8 years, a slightly greater body surface area, 1.96 square meters versus 1.91 square meters, slightly higher body weight, 77 kilograms versus 74 kilograms, as mentioned, a sex difference, and we found a shorter professional athlete career, 11 years versus 12 years. Left ventricular volumetrics showed a difference in end-systolic volume of 2 milliliters per square meter, so it's indexed for body surface area. In athletes with hinge point LG, we found 53 milliliters versus 51 milliliters, and we also found a slightly lower ejection fraction of the left ventricle, 1.2% difference, so 55.5 in hinge point positive athletes and 56.7 without. We found a similar result in the right ventricle. Again, the end-systolic volume was slightly greater and the ejection fraction was slightly lower. So 3 milliliters higher for the end-systolic volume and 1.3% lower ejection fraction. In T1 mapping, we found a non-significant trend towards lower native T1 values, and the extracellular volume was 0.8% lower in athletes with hinge point LGE. So that's 24.5% versus 25.3%. Using logistic regression modeling, including the significant univariates in a multivariate model, in cases where there's a low variance inflation factor, we found that male sex and lower LV ejection fraction were associated with the presence of hinge point LGE. In the most right column, you can see the variance inflation fraction which depicts collinearity, and it's all lower than 4 in this model, which indicates a low chance of collinearity. And the odds ratios for male sex can be seen here. Our results demonstrate a high prevalence of hinge point LGE. For context, a prevalence of only 3% has been reported in non-athletes. And our data show that especially young athletes early in their careers with large body surface areas display hinge point LGE. We suggest that it likely reflects early remodeling, as the workload in these younger athletes may exceed the degree of cardiac adaptation achieved so far. Additionally, our data suggest sex-specific cardiac response, and we hypothesize that a hinge point LGE is a transient finding, as indicated by a lower prevalence in older athletes in the same sports categories, and it does not represent fibrosis. However, because our study is cross-sectional and longitudinal data, preferably from the elite cohort, are needed to confirm our hypothesis on the transient finding. And ideally, this should include strain data, LGE quantification, and athlete performance parameters. So in conclusion, our study in 309 asymptomatic elite level athletes, we found a 40% prevalence of hinge point LGE and a significant difference between male and female athletes. We also highlight its presence in younger athletes, and we suggest that hinge point LGE reflects a physiological remodeling rather than fibrosis. A hypothesis that deserves careful longitudinal follow-up. On behalf of the elite investigators, I thank you for this opportunity and for your interest in our study.
Dr. Verwijs, thank you very much for this excellent overview of your study, which is valuable in terms of our insights and actually quite complementary to the findings of the VENTOUX study that has been presented earlier. At this point, I'm going to invite Dr. Thiago Quinaglia to present his editorial comments. Dr. Quinaglia is a PhD in pharmacology and a cardiologist with an interest in echocardiography, advanced cardiac imaging, including cardiac MRI, and is a researcher in ventricular remodeling, endothelial dysfunction, and sports cardiology. He has previously worked at Mass General Hospital to further these research interests, and is currently affiliated with the State University of Campinas in Brazil. So we look forward to hearing your comments, Dr. Quinaglia.
Thank you. First of all, I'd like to disclose that I'm not a marathon runner, but I can say that I am a recreational runner and a tennis player. So maybe that qualifies me to talk a little bit about this. And also that I'm very pleased and honored to be here. I'm also really delighted to be talking about such an important study. And I hope everything can see my slides now. So we're all here because we're trying to understand what are the differences between healthy cardiac adaptations from maladaptations or pathology in hearts of athletes. And in the recent few years, there's been a hypothesis of a U curve of the relationship between exercise training and cardiovascular effects. Could high intensity, high volume training be deleterious to the heart? These are the questions these researchers are beautifully trying to answer. And we know from previous studies that LGE is it's very prevalent in athletes. And as you can see, hinge point LGE is one of the patterns that are most seen in these athletes. But also athletes that present with hinge point LGE, despite having a similar age in these previous studies, they have greater VO2 max. They have practiced endurance sports for longer, and have greater RV volumes according to some of these studies. And however, they show in some of them a lower RV ejection fractions. And when that is present, some of these studies also show that these changes are related to ventricular arrhythmias. Also, the duration, it's a duration-dependent increase in dysfunction. So we see from endurance athletes, especially those who do high volume and high intensity training, as you can see in the graphics on the right, they do show right after the exercising and a bit after that, a reduction in an RV ejection fraction and also RV global longitudinal strain, which are markers of RV dysfunction. In a study that we are here to talk about today, we've also seen that association as presented just a few minutes ago, and at least in univariate analysis, we see that hinge point LGE is related to reduce LV ejection fraction and also reduce RV ejection fraction. So that would raise the concern of would hinge point LGE be a risk factor? In multivariable analysis, as shown, LV ejection fraction is the one who remains in the model. So there's this association. One of the two variables that that predict the presence of hinge point LGE as proposed by the authors. But to the author's point that hinge point LGE is a healthy feature, we also see in the paper an association between hinge point LGE and lower T1 native measurements, as well as lower ECV fraction measurements. So would that show that hinge point LGE is actually a marker of cardiac health? In previous studies, we've seen that lower T1 native measurements and ECV measurements are linked to athlete's heart, and they could be used to differentiate dilated cardiomyopathy from athlete's heart features. And that is also related to sports modality. So sports that associated with endurance efforts are the ones that show lowest values of T1 in T1 mapping. So sports modality is something that should always be studied in this analysis, because they seem to be very important to understand the clinical importance of LGE. A second point to be raised here is the prevalence of LGE in athletes. And in the study that was presented today, LGE was highly prevalent in spite of the fact that the athletes were really young, an average 25 years of age. Previous studies have shown that this prevalence ranges from 0 to 17%, and a systematic review has shown that the average is around 5.9% occurrence. So the prevalence of 40% is comparable to what is seen in older athletes. So as we just saw in the VENTOUX trial, and here in a previous study, LGE prevalence was around 50% in veteran athletes, but having around 57 years of age. So that again raises that concern. Would that be a risk factor in a sense of, are these young athletes undergoing high intensity and high volume training? Of course, this is a question to be answered, and hopefully the authors will present those data to the audience in upcoming studies. And a third point, but not least important, is and the authors should be given kudos for that, is the sex-associated analysis. So we know from observational studies that sudden cardiac death is much higher in men than it is in women, and that difference increases especially in athletes. So that difference is even higher in athletes. So that raises the information that athletes, women athletes' heart is different from men's athletes' heart, and other observational data corroborate with that. So this recent study in female athletes have shown that women hardly ever show increased LV thickness. So we don't see LV thickness of above 12 millimeters. That's really rare. Also, prevalence of LGE is also lower when compared to men. So those are important two aspects. And in this same study, gadolinium enhancement was shown in around 35% of women, and they were mostly the hinge point LGE pattern, which was also seen in the study by Verwijs that presented today so nicely. And so we see the prevalence as shown of 30% in women, as opposed to 47% in men. And those two, again, those two variables, sex and LV ejection fractions, were the two only predictors that remain significant in the multivariable model. But in this last final model, it remains the question whether if there was any adjustment for training volume and intensity or spot fidelity, if those results would sustain. So lastly, I would like to close with the remaining gaps in my view and on the authors of this editorial view. So as the authors proposed, is hinge point LGE transient? Maybe that would answer the question of why hinge point LGE's prevalence is so high in such young patients. Maybe in a follow-up scan, they won't have as much LGE. Also, we need to see some clinical data. Is hinge point LGE related to long-term clinical events? Also, is it related to relevant arrhythmias? And here, most importantly, ventricular arrhythmias. And also, if there's a genetic background to the prevalence of LGE, and if there are any genetic predisposition to that mediates fibrosis and arrhythmias. And lastly, is this difference of sex-associated LGE clinically significant? Meaning, is it hinge point LGE is just a bystander here, or is it related to differently in sexes? Is it related to clinical outcomes? With that, I'd like to thank you again for the opportunity and congratulate the authors for the great paper. Thank you.
Dr. Quinaglia, thank you. That was very insightful and thorough. And I'd like to also thank all the authors who have presented today. Really remarkable work, and congratulations. I'd like to open now for panel discussion with all our experts here on the panel. And thank you for sending through the questions. I might just pose the first question to the panel that's come through from the audience. Do we know what the incidence of non-sustained VT is in unselected older athletes and non-athletes? And the follow-up comment was, in patients with implanted devices and normal hearts at a similar age, the incidence of non-sustained VT is very, very high. And I think this question is perhaps aimed at the VENTOUX study, which was looking at older male athletes.
Shall I make a start on this one, and then maybe anyone else can be welcome to join in? So this is why we did VENTOUX. This is the question that we were asking ourselves. We'd done preliminary studies. We'd seen scar on the MRI. We'd seen the infralateral scar. We know from other conditions, myocarditis, hypertension, you see scar in the same place, and in all those other conditions, it's associated with arrhythmia. But we really wanted to prove that, and that's why we did VENTOUX. The simple answer is no, we don't know. We don't know what the incidence of non-sustained VT is in unselected older athletes. I know ours, were pretty highly selected. and we don't really know non-athletes too. There's very few studies, that have implanted loop recorders in the general public. Our study was only 106 participants, and it was expensive and very, very time consuming, and we spent a lot of time going through a lot of ILR downloads. And to do that in a bigger study of unselected people in the general population is it hasn't been done as yet, and may never be done because the cost would be so high. With regard to comparing it to patients with pacemakers, yeah, sure, the incident that people do have non-sustained VT, but a lot of patients with pacemakers may not necessarily have completely normal hearts, so it may be a difficult comparison to make. The final point we'd make is that we weren't expecting to see 3 cases of sustained VT in VENTOUX, and I think these were 3 people who were completely fit and healthy with no pathomedical history at all, who have had symptomatic sustained VT, who in 2 years of follow-up, who've gone on to have gone from being healthy people to becoming patients, and so that really did surprise us, and we weren't expecting that.
May I make a couple points too? So I want to just echo what everybody has said. These were 2 remarkable studies, and I really want to congratulate the investigative teams for having conceived and designed and rigorously completed these studies, and it was really a pleasure. I think that the hinge point, insertional point story is very clear, consistent across these 2 studies. High prevalence, probably not pathological, right? But the scar that was seen in VENTOUX is particularly distressing, as Dr. Swoboda was just describing, because we believe in MRI that scar is probably permanent. It doesn't go away. And so in my mind, like, the studies introduced there's 2 important unknowns, which really need to be the subject of further investigation before, as Katie said, we can make recommendations to people. The first is, as we said, how much is too much? At some point, something occurs where either it's an excess of stress or some other environmental condition or a pre-existing proclivity to develop scar in the context of exercise. So we need to understand, for all the people out there who are exercising at a high level, how do we instruct them to modulate their activity so they reduce their risk? And the second question, which I think is even more in some ways distressing, hate to say distressing, we're going to learn something from this, but it is, once that scar exists, then what do we tell people? Because we've already kind of demonstrated that there's a high association between the presence of scar and arrhythmia risk, and so then what do we do? And there is a lot of, and this group can talk about it, there's a lot of literature on return to play following myocarditis and scar. We learned about this in COVID, and potentially we can extrapolate some of that guidance here. But I do think that those 2 important questions really are what really need to be next answered, maybe by multiple studies, I would say. As well.
Those are great points you'd made, Dr. Ruberg. Just as a follow-on before we go to the next question from the audience. So clearly Hinge point LGE looks like it's not associated with adverse outcomes, but from one of the studies, the basal inferolateral wall was. There's a lot of hypotheses for hinge point LGE, maybe bigger volumes, bit of shear stress causes that appearance, maybe it's adaptive. But for the basal inferolateral wall, is there any insights as to why that particular area might be lighting up on late gadolinium sequences?
So that's a really good question. There are a few. The simple answer is we don't know, but there are a few possible reasons. Firstly, it's characteristically a part of the heart which is affected by myocarditis, and we know that athletes who train with viral illnesses are more likely to develop myocarditis, and they may be asymptomatic from that. So that's one theory. The basal inferolateral segment of the heart is potentially an area which is liable to more shear stress from sort of high blood pressure during exercise and more tension on that free wall, and therefore a previous study by Tahir et al. in America shown that exercise-induced hypertension was associated with fibrosis in their cohort. We didn't quite find that association with ours, although there was a slight trend towards participants with fibrosis of that area having a slightly higher exercise blood pressure. And then there's genetic conditions such as Anderson-Fabry disease, which again typically demonstrates a form of fibrosis in this area as well, which may suggest that certain participants who have got a concealed genetic cardiomyopathy or a high polygenic risk score that then may lead to that particular of the heart being more liable to developing fibrosis. Feel free to add, Peter, if there's anything.
Yeah, I would just to add to that. So we see a very similar pattern of fibrosis in patients with arrhythmogenic mitral valve prolapse. And, you know, that's clearly a mechanical process that's leading to fibrosis. And I suspect, because this is all speculation, I suspect that this is a mechanical process that leads to fibrosis, because whilst we do see it in younger athletes, it's pretty rare, and it seems to be related to training, you know, the cumulative exposure in our study. And for the same reason, although we really haven't got the data to say this isn't genetic, my instinct is that the genetic component is likely smaller because again we're seeing it later on and we're seeing it training load dependent. But I think these are the two big areas, you know, that I really want to investigate in the future. You know, mechanical shear stress and either prove or disprove the genetic predisposition.
These comments are really insightful, and I know Dr. Ruberg in his editorial gave some really outstanding hypotheses about different mechanisms, particularly, you know, athletes. Does it suppress their immune system? Is there some component of myocarditis? And I think the comments you've just made are a segue to the next question that has come from Dr. Ozawa in the audience. And Dr. Ozawa noted in the first presentation, there was no significant differences in training volume between athletes with and without arrhythmias. Does this suggest that the relationship is not simply exercise load equals fibrosis, but rather other factors such as genetic, which you've just commented on, Dr. Swoboda, or subclinical cardiomyopathy or prior myocarditis or microvascular dysfunction may play a role in the development of fibrosis? So I think you've answered genetics and some of the other concerns there. How about prior myocarditis or microvascular dysfunction? Is there a role in this type of observations that you've made?
Well, we performed quantitative myocardial perfusion. We didn't find any differences in myocardial perfusion reserve between the groups. Suggests that microvascular dysfunction was not present in our cohort. And in terms of I agree with Koya Azoya's take of this, which is that simply exercise load itself does not simply equate to fibrosis, and there's likely modifying elements to that, whether that's you know, personal genetic and environmental reasons. It's also worth noting that a lot of the studies that we do in athletes, we don't always capture the nuances with athletic training. We recruit, we ask athletes how many hours of exercise do you do per week, how many years do you compete, etc. But you know, our study was performed in Yorkshire in the UK, and if anybody's ever been to Yorkshire, they realise that the people participating in this study, you know, we had one time trialist who said that he would only come off his bike if he finished a race or he got hit by a car. So, and that's the type of mentality that some of the athletes were training with. And you can imagine a person like that who gets acute viral virus is going to continue training. And I think that we can quantify in hours, but it doesn't always tell you how hard they are training, and that's something as well that we're hoping to sort of follow up in future studies with certain things. So, but yeah, to answer the question, I completely agree that this is multifactorial, and it may be that you have two athletes and one of them has a sort of a safe exercise threshold before which they then develop fibrosis.
Thanks very much for those insights, Dr. Javed. It's really intriguing, and I think a lot of work needs to be done further to clarify. We're at time, and there are so many other questions that we'd want to ask, and I see Dr. Dorian has posed another one, which we might answer offline. I might just invite Professor Negishi to give some closing remarks, only because we've hit the limit of the session.
Thanks, Chadi. Yeah, it is. I completely agree with you. We would love to continue this session, but because of the time limitations, we need to close the meeting soon. And thanks very much again for the doctors, the Verwijs and Dr. Javed and Dr. Swoboda for the excellent work and the presentations today. And then also thanks to the panels for sharing your wisdom and thought on this topic. We learned a lot from all of you. And together, this study remind us the cardiac remodeling is not binary. It's a continuum shaped by age, training load, sex, and genetics, and probably myocarditis or infections. And in our challenge as a clinician and scientist to recognize when adaptation tips toward vulnerability and guide athletes safely through their spectrum and also our community. With that, and thank you very much for joining us, to our audience as well for the Circulation Cardiovascular Imaging webinar for today. And let's keep collaborating across physiology, imaging, and sport to ensure that the pursuit of peak performance remains the heart safe for all of us. Thanks very much for joining us.